later. I am starting that recording now. And I'd like to send it over to Dr. Kimber McKay for introductions. Thank you.
Thanks, Patrick, and welcome everybody to our Monday seminar series. As you all know, in the spring, we co-host this with the program in Global Public Health, which is an undergraduate minor on our campus. And today we are welcoming Dr. Donna Bainbridge as our speaker. And not only does Dr. Bainbridge teach on our campus, but she is also a steering committee member of Global Public Health. And Dr. Bainbridge is a practicing physical therapist and has been since 1967. She received her physical therapy master's from UNC Chapel Hill and her EDD in motor learning and sports psychology from Boston University. She has worked in many aspects of the profession, including clinical management as a university educator, researcher, and project director, and director of practice at the American Physical Therapy Association. She has directed several projects on fitness and wellness for persons with intellectual and developmental disability for the University of Montana's Rural Institute and also Special Olympics. So Donna is the Special Olympics Global Clinical Advisor, Fitness Programming, where she coordinates global development of fitness assessments and trains physical therapists to host the Fun Fitness screening in their countries. She coordinates the World Confederation for Physical Therapy Network for Intellectual and Developmental Disabilities and teaches the health aspects of aging online for the University of Montana, which is a course that figures quite prominently in the GPH minor. Her current research interests are validation of balance programs for adults with intellectual disability and development of normative data on fitness parameters, also for those with intellectual disability. And so her talk today, The Three-Legged Stool, Special Olympics Strategy to Promote Global Health Equity for People with Intellectual Disabilities, is this is what she's going to be talking about today. So Donna, welcome, and I'll let you take it away. We typically like to end around 20 minutes to the hour and have Q&A for the last 10 minutes and let people go at 10 minutes to the hour so that they can get to their next thing. And I am just going to pop into the chat the link to our speaker series for folks who might like to browse it and see what's coming up next in our global health focused speaker series for this spring. So Donna, take it away.
Okay, thanks very much, Kimber. I'm honored to be able to give this talk today. Whenever I can talk about Special Olympics, I love the opportunity. So what I thought I would do today is really look at the strategy of Special Olympics to try to promote global health equity for people with ID. So let's start off by kind of getting on the same page and defining what intellectual disability is. So intellectual disability is a term that's used when the person has limitations in cognitive functioning and in skills. These usually occur before the person becomes 18 years of age, can even occur before birth. And these limitations can cause a child or a youth to develop and learn either more slowly or differently than a typically developing child. So the official definition that everyone in the field now uses has been coined by the American Association of IDD. And there are 3 criteria that must be met to be classified as someone with intellectual disability. You must have an IQ that's 70 to 75% or below. You must have significant limitations in 2 or more adaptive areas. So this could be communication, self-care, getting around in the community, etc. And then the condition has to manifest before the age of 18. The 5 most common types of ID that we see and that are actually part of Special Olympics are autism spectrum disorder, Down syndrome, Fragile X, fetal alcohol spectrum disorder, as it's now called, and Prader-Willi. We, however, in Special Olympics, have a very large variety of people who belong with intellectual disability. For example, if a child has a traumatic brain injury prior to the age of 18, they could also join. So this allows us to have a large population, but it also complicates things for us when we're trying to look at data. How common is intellectual disability? It's generally figured that approximately 1 to 3% of the global population has the ID. So that is about 200 million people. These percentages vary in many countries. For example, in the United States, we have an incidence of 1% or lower. But in low and low middle income countries around the world, the incidence tends to be significantly higher. New data suggests that the prevalence may actually be decreasing. And whether this is decreasing because it's decreasing in certain countries or generally in all countries is not yet known. But the new data suggests that the numbers might be slightly going down. In the US, if we look at our country, we have about 6.5 million people that have intellectual disability. So we're talking about a pretty sizable population of people. There are 4 levels of ID from mild to profound. I think the key point here is that in the United States, over 80% of the people with intellectual disability have a mild intellectual disability, and only 3 or 4% are severe or profound. So we clearly are weighted toward the other end of the spectrum, from 80% with mild, a huge percent, probably 15% with moderate, and then only a very few percent with severe and profound. This really means, and this is the significance of this, that these individuals can learn, they can work, they can live in the community with some supports. So I think, that's something to think about in the US, because they're all mild, they really have the ability to live a much more normal life than if they had a more severe form. The percentages of ID in terms of the degrees of mild, moderate, and severe really vary greatly per country, secondary to the etiology or the cause of the ID, socioeconomic status, and medical care that's available. So in terms of the scope of the problem, this is the good news. The good news is because of more appropriate support and care, life expectancy has increased dramatically. 20 to 30 years ago, the life expectancy used to be 20 to 25 years. Now people with intellectual disability can live to more than 60 years of life. And this is true particularly in the mid to higher socioeconomic populations. The bad news is people with ID still die 16 years younger than most other people of their same age. They are definitely a medically underserved population. There's inadequate and unequal access to healthcare, and there's inadequate provider reimbursement for healthcare. Training of providers, healthcare providers, relative to ID is limited or non-existent. And there are still a lot of physical, attitudinal, communication, and social barriers that exist and thwart access. The one other thing I'd like to add here is because they are living longer, living to 60, 65 years, which is a relatively normal life expectancy, they are also being burdened with everything that we are burdened with as we age. Non-communicable diseases. They're getting diabetes, they're getting arthritis, they're getting cancer, they're getting kidney disease, all the same non-communicable diseases that the rest of the population is burdened with is now also beginning to burden this population. So to sum up the global problems, half of the people with ID cannot afford healthcare even when it's available. There's poor development in childhood. Their general health is much more fragile. There's increased dependency on others for their needs and their ability to survive in the environment. Much higher rates of poverty both in this country, but definitely in other parts of the world. 49% are more likely to never attend school. We've been in many countries where the parents will say that the kids go to school, but then they don't know what to do with them when they're in school, or they don't go to school at all. There's still a lot of social stigma about ID, that it's a shaming condition, that it's a curse, that it's a burden that was given to a family for something that they did. And so in a lot of places, the families still keep the children in the home for their own safety. The World Health Organization has noted and has been really focusing on reductions in child mortality, and they have occurred. But they are now noting that those reductions in mortality really have to be paralleled by early childhood development initiatives. You can't have children living and not then support their development, because these children have a lot of developmental issues that need a lot of resources and funding thrown at them to help them develop more normally. Special Olympics, you might ask, how did they get involved in all this? You know, Special Olympics is a sports organization, and they really were a sports organization until the early 2000s. But when they realized the health inequities that were occurring in this population, they decided that in order to really promote inclusion and equity, they needed to embrace public health in some way. So in 2001, at the World Games in Alaska, we had a Senate hearing that was attended by the senators that were on the Appropriations Committee at that time. And there was also a meeting called by the Surgeon General. It was an invitational meeting. And the result of that meeting, which is still published and available, is a report called Closing the Gap. And this report really looked at the health disparities in this population and the needs to really address these disparities. So at this point, Special Olympics went global. They got 7 regions and globalized and began looking at public health as a way to address these disparities. So if we just look at the population of Special Olympics, and I will say that we are trying to impact people with ID regardless of whether or not they're members of Special Olympics. I mean, that's the end goal. But we have to start with our own populations as models to reach out to larger groups. So if we look at Special Olympics and their size at this point, there are over 250 Special Olympics programs in over 200 countries and jurisdictions around the world. And I've outlined how many programs there are in the different regions of the world. We are impacting now over 5.5 million, almost 6 million athletes, and 500,000 young athletes. And the reason we break them out is because according to Special Olympics rules, you cannot be an athlete and compete until you're at least 8 years old. And so the athletes that we define here as over 5.5 million are athletes who are over the age of 8. We also realized, though, along with the WHO, that we needed to begin earlier to impact people with intellectual disability before they got into the competition stage. So we've started programs for young athletes programs, healthy young athletes programs that really look at motor skill development and socialization and some of the other earlier precursors of involvement in activity. So we are now, as a department, called Special Olympics Inclusive Health. And the goal is grandiose, to create a world where people with ID have every opportunity to be healthy and are able to take full advantage of the same quality health programs and services that are available to people without ID. And that's a large order, but that's the ultimate goal of this program. So here's our three-legged school. How do we do this? And I think the reason I'd like to present this as a model is I think it has a lot of bearing on other groups. You know, this is the way that we've approached it, but I think a similar approach would apply to other groups who are underserved. First of all, we decided we had to get in there and provide some kind of health care. These people were not getting health care, especially in other parts of the world. You know, in our country, under the age of 18, the health care is fairly good. Over the age of 18, many of the services fall aside, but we still have health care available. But in other parts of the world, they have little or none. So the first leg of the stool was we had to give them some health care. The second leg of the stool, if we really wanted inclusive health, is we had to do something in the community. We had to create options for inclusive, equitable community health. And the third part was we've got to change the system, and we've got to change policies in order to really make sure that people with ID are equally included under policies and systems. And I've put a link there that you can go to look at this whole process. So leg number one, provision of health screens. We devised a group of health screens that are free. We not only do health screening, but we educate, and we're educating athletes, coaches, and families. We often provide equipment, and we refer back to their community for healthcare services they may need. This program is called Healthy Athletes. The objective of this program is not only to improve the health of the athlete, but that was the core reason. But we also want to improve healthcare for them. We want to increase access for them. We want to train healthcare professionals to do these screenings so they have exposure and learning about working with people with intellectual disability. And we want every one of our volunteers to become advocates for improved and equitable healthcare. So the objectives are much more broad than just providing health screens. This is now what Healthy Athletes consists of. It has 8 components. Opening Eyes is a vision screening. Special Smiles is a dental oral health screening. Fun Fitness, which is the one that I developed, is a fitness screening. Healthy Hearing is an audiology screening. Health Promotion is many of the aspects of healthy lifestyles, including healthy eating. We do bone mineral density. We do BMI, tobacco cessation and avoidance, sunscreens, and protection of the skin. Fit Feet is a podiatric exam that looks at the feet and ankles and often monitors how they're walking. MedFest is our sports physical exam, and Strong Minds is a stress and coping skills session. The things that we give out, Opening Eyes actually does supply glasses, sunglasses, and protective lenses if they need it for their sport. Special Smiles provides custom and standard mouth guards. Fun Fitness provides some exercise tools like exercise band and stretching bands. Healthy Hearing now is able to provide vouchers for hearing aids. Fit Feet usually supplies sneakers because in many parts of the world, you'd be amazed at the things that come on their feet. And MedFest, as I said, is basically a sports physical. So what has been the impact of Healthy Athletes? And I just chose the most recent 3-year period. We have done over 500,000 screenings. And we've gotten 51 to 52,000 referrals from those screenings back to their communities. We've trained over 150,000 healthcare professionals and students. And we have almost 3,000 local health and wellness partners. So And this is just in 3 years. If you go back to the beginning, when we started in 1992, we've probably done over 2 million screenings at this point. So the next leg is community-based health and wellness programming. These people live in their community, so it does no good for us to do health screenings and teach them all this stuff and then not connect them back to their community. So we need to connect them back to their community, not only for health care, but for health promotion and healthy living initiatives and health. This is where the health inclusion and the health equity really needs to take support. So our healthy community program, which is what we call it, really focuses on the whole person. And we're trying to provide integrated healthcare, health promotion, and wellness services in their communities. This can really be tailored to the specific needs of the community. And I'm going to give you a couple examples of this so you'll see the different emphasis that has been placed on this. And it really encourages the partnerships with the local resources and organizations. We have a program where you can get a grant to become a healthy community, and there are certain criteria that you have to meet in order to become a healthy community. You have to have healthy athletes, you have to do programming in part of your community, et cetera, et cetera. So you can actually almost get a certificate to become a healthy community. So one aspect of healthy communities is fitness programs. You know, every community has fitness programs, and we want to have programs that are inclusive of people with ID. So on the website of Special Olympics, we have some evidence-based and validated programs that have been validated in people with ID. And both the description of the program and the materials, all the materials they need, are available online. So a community could just go online and print this stuff off and start the program. The 3 models that we've created are unified fitness clubs, and they are clubs of people with and without intellectual disability who get together on a weekly or a bi-weekly basis and do an activity. They could choose their own activity. It could be cycling, swimming, walking, whatever. And they keep track of their activity levels, and then they give them rewards for attaining certain goals. Fit Family and Friends is a program that encourages families to work with their children and siblings, and again, choose a fitness or nutrition goal and try to achieve that over a 6-week period. So Fit is an 8-week fitness program that can be done as a group of people with intellectual disability and including siblings and people without intellectual disability. And all the materials for that, as I said, are online. We also have done fitness training for coaches. Our coaches run from soup to nuts in terms of what they may or may not know about fitness. Some of them have never been coaches before and are just volunteering. Others are very experienced coaches. So we have an online learning portal, and we've actually done a fitness training program for coaches so that they can incorporate fitness into their pre and during season training programs. Special Olympics has also developed 2 programs of their own. One is called Fit 5, and this is a resource guide that has training cards and videos, has logs for them keeping track of what they're doing. The goal here is very simple: 5 days a week of physical activity, 5 glasses of water a day, and 5 servings of fruit and vegetables. This other thing are performance stations, and these are stations that really try to prepare the athletes to compete at their personal best. So this is a link between fitness and performance so that they can understand how being fit and hydrating and stretching and warming up will improve their athletic performance. And again, these materials are online. The other thing is we have really embedded fitness in schools. We have two kinds of processes. We have what we call unified schools and unified champion schools. Again, have different criteria for achieving them. And you can see the number of schools that we have. But this is really a multifaceted project that uses both sports and education to activate young people as change agents and to generate positive and healthy interactions between those with and without intellectual disabilities. Unified sports is another component where we are bringing together athletes of similar age and ability, some with ID and some without, for training and competition. And this really promotes development and positive bonds between the partners. And we have unified sports in just about every sport at this point. And it's been very popular, and we have a tremendous number of unified athletes. I think there are over 500,000 unified athletes at this point. So we have beginning data coming in on fitness programming. So what is the impact of this? A third of the participants have increased their physical activity. Half of the participants are eating fruits and vegetables. And half of the participants have increased their water consumption. In those who are most at risk, a quarter of them have lost weight, and overweight athletes have had their blood pressure really reduced. So we're hopefully reducing cardiac risk as well. I just want to show you the expanse of this healthy communities. And so we have 68 recognized healthy community programs at this point. And the purple ones are the ones that are healthy communities. The blue ones are the ones that are just beginning. So you can see how this is spread really around the world. And just to give you a few examples, we have one in Montana, and this tells you some of the things that they're doing as part of their healthy communities. They have Fit 5 programs in 5 communities. They're doing a Stride 8-week distance challenge. They have healthy athletes. They do a monthly health newsletter. They're training health messengers, which is the training for athletes who want to become positive, proactive messengers of health for other athletes. And then we've worked with Montana 211 to really beef up the resource development for people with ID who need healthcare, counseling, etc. What are they doing in Kenya? Well, in Kenya, they had a huge problem because children with ID were considered a curse, and they were often hidden at home by the family. So what they chose to do with their healthy communities was to develop a special needs unit at one of their primary schools and offer not only health programs, but food, games, self-care skills, taught them how to cook, how to take care of their cleanliness, how to hand wash, and also educated the parents. So now the children are healthy, the parents value them, and they're not afraid to have them go out of the home. And they go to the school and they can now learn with the other children. In Slovenia, they've decided to focus on promotion of healthy lifestyles, not only in athletes, but in families and coaches and peers. So they have workshops on nutrition and health. They run exercise sessions in year-round fitness, do healthy athlete screenings, and they have a system for follow-up care. So if they do a screening and they need follow-up care, they help facilitate that. Venezuela, they decided to focus on breast health. So they do both male and female mammogram screenings with one of the local healthcare mobile facilities. And they're also educating their athletes in breast self-examination. In Jordan, they decided that they really needed to coordinate between the ministry and the universities. So the university there has added a healthy communities module to their degree requirements, and the module includes both coursework and volunteering. So you can see in Thailand, there's no healthcare available in rural communities. So they decided to create a network of providers to treat those with ID. And then they conducted special trainings for those people to deal with the healthcare needs of people with ID. So you can see that they're really tailoring those programs to their needs. We've had other programs that have given out mosquito netting because of problems with malaria, have focused on clean water and hand washing. They really can focus those programs on what they need. Okay, so the last leg, we've now dealt with healthcare. We've tried to redo the community, but now we really need to work from the top down. The other two programs kind of work from the bottom up. They're grassroots efforts that are dealing with health and community-based programs. We now have to make sure that the whole system and the policies that are developed are inclusive and equitable for people with ID. So we, as Special Olympics, developed the Center for Inclusive Health. It's online, the link is there. We launched it in 2018. The goal here is to encourage organizations and leaders to take action to achieve inclusive health. And so in order to do that, we have provided resources and opportunities for knowledge sharing. We have a lot of white papers on there about the importance of inclusive health and why health disparities exist. And we also are highlighting promising practices and strategies to try to achieve inclusive health, be it in the government, be it in an organization, etc. But I wanted to give you some examples of how we on a larger scale are trying to impact inclusive health. We had a regional games in the Middle East, North Africa, and we had a delegation of UN agencies come and observe those games. The reason was to see how countries can be helped by running games like this to implement the Convention on the Rights of Persons with Disabilities, the Sustainable Development Agenda of the UN, and other UN conventions that protect health and human rights of people with ID. So these UN people came to observe how things like the games could be productive in terms of health and human rights for people with ID. We also have a signed agreement with PAHO, the Pan American Health Organization, to ensure that all their health systems in the Pan American countries are inclusive of people with ID. We worked with SLEN and WHO to really shape the conversation on the best ways to protect human rights of people with ID. And human rights also includes not only rights to life and to not be abused and to have same opportunities as everyone else, but the right to health. Special Olympics puts out a bid, like the Olympic Committee does, for countries that want to hold our summer and winter games. And our summer and winter games are the years opposite the actual World Games. So they're running Winter World Games right now. Next year, we are running Winter World Games and Summer World Games in the same year because we had to put them off because of COVID. So our games run in the opposite years. We put out bids for sites. So the ability to have the infrastructure to hold the games is certainly a consideration. But also we choose countries where we can leave a legacy, where we can change systems and attitudes in that country so that there's a legacy left for people with intellectual disability. Since the politics of China are high on the list of everyone's mind nowadays, I'll use them as an example. We held World Games in China, Summer World Games. And prior to holding the games in China, you can imagine what the situation was for people with ID. With the one-child policy, people with ID were not even considered part of the population. Many times they were left to die, horrible things happen. Now in China, we have Special Olympics China, Special Olympics Hong Kong, Special Olympics Taipei. They have activities, they have supporters at the highest level, there are daycare centers. So that's the legacy we want to leave. Japan. We don't think of Japan as having any attitudes against people with intellectual disability, but Japan is so technological that they do very well with people that have moderate to severe disability. They do less well with people with mild disability. So we were able to change those attitudes and leave a legacy in Japan. So we had our last games in the UAE, which again has been an area that has not really had the best human rights record for people with disabilities. And we have left a huge legacy there in terms of the games that we had there last year, 2 years ago, in terms of having them really be considered athletes of exceptional quality. We had a world tennis tournament in the Dominican Republic, and we used that as an opportunity to train government officials and healthcare workers to understand and address the health needs of people with ID. So you can see these are all different aspects of ways to approach the problem, but all approaching the problem from much higher levels. A group was just formed, and it just was launched before the Paralympics in 2020, called We the 15. It is a collaboration of international sports, human rights, and business organizations that are trying to initiate change for people with disabilities in general. But this is the first time that Paralympics, Special Olympics, the Invictus Games, and the International Committee of Sports for the Deaf have been included and are collaborating in including people with physical and intellectual disabilities in this group. There's another formalization of partnership that just occurred between Special Olympics and the Population Funda. 179 governments committed to empowering youth with ID, especially women and girls. So they're getting special protection and greater access to health services, but also highlighting sports opportunities as a way to empower and level the playing field. So that gives you an example of how we're trying to work on the highest levels from the top down to ensure that we have our populations recognized by inclusive and equitable health and human rights. And at that point, I will stop and see if we have any questions.
Thank you so much, Donna. That was so inspiring and so interesting. I think you know that I've worked together with multidisciplinary teams primarily, but not exclusively clinicians, in a neonatal ICU, the first of its kind in Uganda. And we have been involved in this fight for getting people to recognize that when the survival rate goes up for neonates, that some of those children will go on to have some of the challenges that you've described here. And so advocating for their rights and for their position in society, that's been something that's been very near and dear to my heart. So I love to see the work that you've done here. And speaking of that, I was wondering if in your mind, will there ever be a time when the Special Olympics will be held in a low resource setting, like in Sub-Saharan Africa or maybe parts of South Asia and so forth?
Well, the way that we're organized at this point, you know, when Special Olympics began 50 plus years ago, there was the central office in DC, and that central office kind of ran the world. Okay. I started working with Special Olympics and developed Fun Fitness in 1999. And so they were still kind of housed in that organization. In 2001, they realized two things. Number one, that there were huge health disparities. And number two, that they had 1 million athletes, half of which were in the US. And so it was like this big eye-opening on those two fronts. So they decided that they had a management assessment, and the management assessment said to them, you have to do two things. You have to go global and local. If you want to expand who you're impacting, you've got to be a global organization and have more people outside the US. But you've got to go global or local because that's where they live. And so at that point, they regionalized. They developed 7 regions, and each of those regions actually runs the region. So the central office now is the main resource, but the regions raise their own money, have their own programs, do their own thing. So we have a Europe-Eurasia region, which has the headquarters in Brussels. We have a East Africa region. We have Asia Pacific region, Africa region, Middle East, North Africa, Latin America, North America. So each of those regions has a regional office, a regional manager, has a regional healthy athlete manager, and they literally run the programs in the countries in their region. So we have decentralized to a large extent. So for example, the African office runs programs through the African countries. So they understand their culture, their languages, etc., and they understand their needs.
Mm-hmm.
So they can grow their health programs depending on their needs. And what we've seen, which has been interesting, let's just take healthy athletes, for example. Each of them start healthy athletes with the programs that they need. So I started programs in Kazakhstan, for example. I went several years ago to Kazakhstan and started programs in all the stands, Turkmenistan, Tajikistan, they were all there. They decided that what they needed to start with was fitness. And so that's how they started healthy athletes. Others decide that they need vision or they need hearing. So they choose how they start and how they grow. They also choose, if they apply to become healthy communities, what they do in their healthy communities. And that's what I said. Some of them in the African region, for example, were concerned with malaria. So their initial healthy athlete programs were teaching and spreading the use of mosquito netting. Or, you know, in that region of the world, the other issue was clean water. So they were doing water filtration systems and hand washing. I worked with a program in Malaysia that was teaching them about hygiene and wearing shoes because all the kids were getting worms from going barefoot outside. So they really do what they need. And that allows them the flexibility to adapt to their own cultures and socioeconomic needs.
And so if I or another person listening to your presentation were interested in sort of doing some of that or encouraging some of that community-based work of the one pillar that you, or leg of the stool that you mentioned, it would be appropriate to approach the regional office and see what work they're doing in that regard, and if that can be extended into the communities where we work.
Yep, that's where I would start, because they'll be the people that have the biggest overview of what's going on.
I see.
And so then depending on what you want to do, they'll know what exists, they'll know what resources are there, and they'll be able to best direct you. Yeah.
Looking in the chat to see if there are other questions coming forward, and I'm not seeing anybody, but if anyone has a question, please unmute yourself and go ahead and ask. Or you could also put your hand up if you want to be called upon. Not seeing any hands up.
Silent group. just to give you another extension to that answer, Kimber, we've had a lot of requests from the Africa region for young athletes. And so, you know, for example, if that were an area that you were working with your neonatal patients, that's been an interest of theirs because they have humongous problems with dealing with the athletes when they're younger, you know, in the early development stages. So because of, you know, the poverty and the kind of social stigma against people with disabilities.
Yeah.
So they have lots of experience in that. So in that area, you know, contacting the office, they would have a lot of experience in that area, for example.
That's really encouraging.
Yeah, the same is probably true in the Asia Pacific and East Asia regions. So
that's good to know. Thank you, Donna. Well, I'm not sure that we are seeing any other questions coming forward. So I think we can probably just leave it there with thanks to you, Donna, for that really fascinating but also inspiring presentation on your work, and so glad to know it better. So thank you. We'll look forward to seeing folks next week. And as you would have seen previously, I put the link in the chat for folks who want to refresh their memory of what's going on in the speaker series. Next week, that's going to be on the Valentine's Day. On February 14th, we're going to be hearing from our colleague in the School of Public and Community Health Sciences, Ethan Walker, who's going to be presenting his research on indoor air pollution and the impact of a wood burning cook stove on cardiometabolic health in rural Honduras. So we'll have that to look forward to next week. And with that, I think I'll just say goodbye and thank you to everybody. Thanks again, Donna.
well, thank you. I appreciate it.
See you soon.